Hello, everyone. Thank you for coming. On behalf of Virtual Path SIG and CAP, the Digital Outreach Committee, thank you for attending this Pathology Subspecialty Speed Dating session today. Just as a reminder, this main session will be recorded. We want to thank you all for your attendance, and we hope this answers some of your questions about careers, education, and subspecialty training in pathology. My name is Jenna Ungst. I'm the president of PathSig, as well as an incoming fourth year at LMU DCOM out in Knoxville, Tennessee. I'd like to thank the other members of the PathSig group, as well as the CAP Digital Content Committee and the new NEAM Future Forensic Pathologist Committee for their attendance today. I'd like to go ahead and just invite our other organizer and moderator, Dr. Lizzie McLeod, to go ahead and just introduce herself.
Hello, everyone. I'm Dr. Lizzie McLeod, and I'm with the CAP Digital Content Committee. We've been working with the Virtual Path SIG to design this event. I am currently a Forensic Pathology Fellow at the Georgia Bureau of Investigation, and I'll be going on to join the Armed Forces Medical Examiner System in Dover, Delaware. I'm really glad that you guys are here.
Thank you, Dr. McLeod. And now I'd like for one of our other moderators, Ting, to go ahead and introduce herself.
Hi, I'm Chang. I'm a current third-year medical student, and I am one of the event co-chairs for Virtual Path SIG.
Thank you, Ting. And now we'd like to introduce our panelists.
Good morning or good afternoon, everyone. So my name is Srikar Chamala. I'm an associate professor at University of Southern California and also director for Pathology, Informatics, and Data Science at Children's Hospital, Los Angeles. I've been in the field of biomedical informatics and pathology informatics for over a decade now. My primary duty is to oversee majority of the informatics systems and also informatic processes within pathology department at CHLA. Again, I'm going to go through in the presentation some of the aspects what I do day to day. In terms of research, I do a lot of genomic correlation with the diseases and also genetic diagnostics and applying AI on the patient outcomes kind of research. And education point of view, I am an associate program director for Clinical Informatics Fellowship Program at CHLA. We just kind of got approval and we'll be taking in students next year as fellows. If anybody's interested, please contact me. Yeah, so overall, I think majority is the clinical work is overseeing the pathology informatics systems and education-wise residency training and fellowship training and the research, some AI is becoming big and I focus on that right now. Thank you all.
Hey, I'm Hansini. I am a breast and gynecologic pathologist at Christian Hospital, currently practicing in St. Louis. I'm very excited to be a part of this panel session, and I'm looking forward to meeting more curious minds who will be future breast and GYN pathologists.
I'm Natasha Grandhi. I'm currently an associate medical examiner both with the Georgia Bureau of Investigation and the Cobb County Medical Examiner's Office. I am finishing up my tenure as the associate program director for the Forensic Pathology Fellowship Program through the GBI as I transition over to Cobb County, also in the Metro Atlanta area. And an additional role that I hold is that I am the vice chair for the Forensic Pathology Subcommittee for CAP. So I have some affiliation there as well. It's a pleasure to meet everyone.
Hello, everyone. My name is John Gross. I'm a bone and soft tissue pathologist and associate professor of pathology and orthopedic surgery. I'm at the Johns Hopkins Hospital in Baltimore, Maryland. I'm also the director of the Division of Bone and Soft Tissue Pathology here at Johns Hopkins, and we have just started a bone and soft tissue fellowship program beginning July of 2026. So we're excited about that as well. And I'm very excited to be here because I love bone and soft tissue pathology, and I'm excited to talk about it more a little bit later.
Hi, my name is Karra Jones. I am a neuropathologist at Duke. I'm also the division director for muscle and nerve pathology. I have a lab director role as the medical director of our immunochemistry and electron microscopy lab, and I'm the neuropathology fellowship program director. I'm really happy to be here to speak to you all today.
Hi, I'm Tony Chang. I'm a renal pathologist at the University of Chicago. I've been here for 21 years, and there's a good chance that a lot of you, if you're in residency, won't spend any time in renal pathology. So looking forward to trying to entice a few of you into our great specialty.
Hi, everyone. I'm Portia Kreiger. I'm a pediatric pathologist at the Children's Hospital of Philadelphia. I'm also the division chief of anatomic pathology, which includes both general pediatric pathology and neuropathology. We have a separate division of hematopathology. I'm also a professor of clinical pathology and lab medicine at the Perelman School of Medicine of the University of Pennsylvania. I've been in practice about 20 years, and I love pediatric pathology, so I'm very excited to be here today. Thanks.
My name is Dr. Lyapichev. Currently, I am director of flow cytometry lab at Cleveland Clinic, Florida, in Weston, next to Miami. Before, I was hematopathology director and flow cytometry director at the University of Texas Medical Branch. I recently moved to Florida. I am more than welcome and happy to share my experience and maybe convince some fresh grads, medical students, or pathologists to choose my path.
Hi, I'm Chieh-Yu. I'm an associate professor at WashU St. Louis. I'm a cardiothoracic pathologist. I also the director of autopsy service and then the frozen section service in my hospital. Really nice to see all you in this lovely Sunday.
Great. We are all so glad to have you here and thank you for taking your time out of your schedule. Lizzie and I will be assisting with the session today. Each speaker will have 7 minutes to introduce their subspecialty. We encourage you to share what you love about it, what a typical day looks like at your organization, what additional training is required, and how students and residents can get involved. This will be followed by 7-minute breakout sessions where attendees will rotate through small group discussions with each speaker. These sessions are designed to foster more personalized one-on-one interactions. The main session will be recorded and uploaded to YouTube for future viewing. Breakout sessions will not be recorded to encourage open and informal conversations. If you have any program-specific questions, we ask that you hold them until that time.
Great. And with that, we'll go ahead and jump into the individual talks. I'll start with Dr. Chamala.
So I'm just going to give you just high-level overview of informatics and pathology, and probably this is one topic which covers almost all the subspecialties, all the panelists what we have who we have today. So I think hopefully at the end of this 5 minutes presentation, I'll be able to convince how cool informatics is and how complicated it is, and also to solving workflow efficiencies across pathology. We know, I think, based on some of the publications and articles before, there is a huge shortage of laboratory staff in the United States, and also globally to some extent. So these are some of the recent publications around it. And globally, there's a lot of scarcity within pathologists. There is a shortage, and we need more people trained in pathology. There's a good job perspective within pathology, given the shortage you see. Again, possible solutions is obviously, inspire upcoming generations of students to train is to pursue careers in pathology and laboratory personnel. Again, this is exactly one of the reasons why we're doing this meeting is to inspire upcoming residents to pursue within pathology. The second thing is, can we use innovation and technology to help accelerate how the pathology is done today? And that's where a lot of the technology and informatics automation can help you, and also with all the AI and large language models we just seen recently, going to help us really accelerate how we do our pathology in practice. And what is informatics? Informatics is basically a study of how data is acquired, stored, processed, retrieved, analyzed, presented in a way data. You take data and turn it into information. That's the whole point there. And informatics is not a new field. Informatics is there for hundreds of years, I guess, because people used to do on the papers, right? Data was there manually in the papers. You used to get information out of it. But now with the computers, we can digitize the data, process in a large scale within a fraction of seconds. So again, overall, this is informatics. It touches every aspect of healthcare and everything what we do in our life. Pathology is no different. Informatics supports whole pathology department and also working with the informatics at the EHR level at the hospital. I just want to show you the complexity of pathology. You have multiple domains, and again, we can see the representation within the panel, how the domain expertise is there. And we have a research within pathology, experimental pathology, and then we have a precision genomic medicine, biorepository, regulatory, billing, and HR. At division level, you have anatomic pathology with multiple subspecialties, clinical pathology with multiple subspecialties, and genomic medicine also with multiple subspecialties. You just want to point out the diversity of the different types of workflows are available internally, point of care testing, secondary opinion, inpatient, outpatient testing, and send out testing, and so forth. And externally, you have a collaboration, or you share the data with enterprise data integration, government regulatory agencies, research, and company collabs. To accommodate all these things, you need a huge computing infrastructure, including storage, desktops, lab instruments, and so forth, infrastructure maintenance. And then you need to configure your EHRs, laboratory information systems, and data analytics tools and interfaces. And oftentimes you also need to develop custom tools to help your particular needs. For example, AI and machine learning are becoming more and more popular in our day-to-day implementations. If you go to the much bigger hospitals, this is going to scale much higher. So you get the point here is we support a lot of lab tests and instruments and so forth. The point here is evolving in landscape of pathology. We are having large scale of data management right now. We are more and more, we are developing specialized assays through laboratory developed testing. We have to make advanced clinical decision making systems, data analytics, using which we can do evidence-based strategies. And oftentimes now we are more multi-institutional collaborative research. AI, machine learning, and natural language processing integration is becoming more and more popular. This makes in-depth informatics training essential. Either you can do full-time informatics or part-time, or even don't do informatics, but at least having some basic informatics literacy is important for all of us. Here, pathoinformatics touches multiple areas in this diagram here. Informatics is a very interdisciplinary approach, team approach. It's interdisciplinary, interdepartment, interinstitutional. Just want to give a high level here. And for my team, we have multiple types of people here. We have app configuration members who configures and builds EHRs, LISs, and data analytics tools and lab interfaces. And then you have members who are infrastructure, based computer engineering kind of people. And then you have expertise in computer scientists, which include data scientists, bioinformaticians, programmers and stuff. They build custom software like AI, ML, databases and everything for our department. So again, multi-scale, close collaboration and synergy. Part of informatics, we manage a lot of computing and application infrastructure. For example, NovaSeq, this is old data in a way. NovaSeq, if you run through this sequencing machine, it generates about 6 terabytes, up to 6 terabyte data in 44 hours, right? It's a lot of massive data. How are you going to manage it? That's where informatics engineering team going to come and help you, navigate through the infrastructure and so forth. And same thing in the AP, digital pathology, same thing. If you are really scanning a lot of slides, you have a ton of slide data also, which need to be managed in a secure manner. Again, these are some of the computing. Right now, the cloud computing has become AWS, Google Cloud, Microsoft Azure, and other things. So again, my informatics team is also responsible for managing this infrastructure. Again, one of the big thing we do is data analytics and data science. Again, this is a publication from MIT's Sloan Management Review. The point here is institutions and companies who use data, they're much more successful. There's a correlation with it. So which means we generate a lot of data, but oftentimes we don't really use it. So as informatics team, one of our responsibility is to aggregate all the necessary data across the institution, across department, and try to do some analysis around it, both for research and also for operational. For example, you can do diagnostic analytics, which is what did happen, and you can do predictive analytics, what is likely to happen based on the data, and then prescriptive analytics. This will help you make a smarter and cost-effective decisions overall, and which obviously improves the outcomes. This is a high level of multiple systems we have in our institution, but something similar but different vendors across other institutions. This shows the complexity of data sources we get and how do we utilize it for decision making. These are some of the data set applications we can do, turnaround time, stewardship, test volumes, business opportunities, quality improvements, research, and other things we can do. So overall, the pathology informatics does have a lot of value generation, especially using data, right? And the saving of costs, data-driven decision making. Informatics can also help us mitigating errors and misdiagnostics. Diagnosis, accuracy, and ease of data sharing. You can deploy cutting-edge technology and informatics tools. It also helps you facilitate effective communication, coordination, collaboration with stakeholders, both internal and external, and also enhance translation research and industrial collaboration, and also boost informatics education. So overall, informatics can help you accelerate and improve, clinical care and clinical outcomes. Day to day, my life or my team's, life is overseeing all the things what I show you today and being able to understand the challenges within the current environment and trying to see can we fill those gaps using informatics solutions. So it's a fun area because every day you go through new challenges, new tools, and not only that, you get to interact with almost everybody across pathology, not only just pathology, but also at the enterprise hospital level, informatics members and so forth. That's what I'm going to stop here. Thank you all.
Thank you. And next, can we have Dr. Laharwani?
Hi, I'm a breast and gynecologic pathologist. I did my fellowship at Washington University, St. Louis. and it helped me so much. So if you're a medical student, I would say that choose a program that is going to lay solid foundations for the basic training that you need in pathology. And if you are a resident, then choose a program that will bridge the gaps that you had in residency, and it will solidify those specialty that you're interested in fellowship. And I'm really grateful for my fellowship program. I'm fairly new in practice. I'm going to start my third year from next month. And my fellowship program trained me so well. It was intense at some times, but I feel that it helped me practice independently. And so if you are a resident, I would definitely advise you to choose a good fellowship program. Whereas about breast and gyne, I would say that, in my specialty, we diagnose diseases of breast and female reproductive system, from benign conditions to complex cancer cases. And we help the surgeons in chemotherapy, surgery, and we help them guide in treatment. This is just a small gist about my specialty and about myself.
Thank you so much, Dr. Laharwani. Next, we're going to have Dr. Grandhi for forensic pathology.
So real quick, I just kind of wanted to give a bit of background information as how you would get into the field of forensic pathology for the medical students that are present. There are a couple of different paths. For forensic pathology, the most important thing is that you get training in anatomic pathology. Most of us will actually receive training in clinical pathology as well, but forensics is one of those routes where the clinical pathology boarding, if not the training, may be optional for fellowship applications. So that means that at a minimum, you're doing the 3 years of anatomic pathology residency, 4 years if you add in that CP training, and then you have the 1 year of forensics fellowship afterwards. I would say that I absolutely love my job. It's a little bit different every day. There are different environments that you can practice in. There are most commonly the government offices, but then there are some private companies that will contract with the local government. You're probably familiar with what we do, which is autopsies. But the autopsies that we do are not just the criminal autopsies for the cases that are all over media, like the homicides. We also investigate sudden deaths, unexpected deaths. Unattended deaths is a very big and not often considered component of our patient population. So we serve a large indigent population, and we get to see some of the extremes of disease processes when we are doing these autopsies, which is really interesting. My typical workday can change depending on whether I am doing cases, so that's actually performing the autopsy, or if I'm in court. Because again, we do some of these criminal cases, so we will have to go to court frequently to testify in not only the homicide cases, but sometimes in the overdose cases. That's starting to become an emerging component of our field, as well as car accident cases because of vehicular homicide charges. We do a lot for public health. We work with our public health departments to track trends. So some of the infectious disease trends, but also things like the emerging fentanyl overdoses, the xylazine things that are coming out that you may be hearing about in the news. Those are gaining a lot of traction, and we have a lot of fatality reviews. So you can have involvement in the mortality of women. That's anybody that's been pregnant within 12 months of their death. That's its own fatality review board. Pediatrics usually has a fatality review board. So there are opportunities to be involved in many different aspects aside from just hands-on autopsy dissection. And I can go into some more of the details and specifics of that when we do the breakout sessions. But I do want you to be aware that it's more than just the gross dissection and autopsy dissection when we're dealing with forensics. We do have a large legal component as well. And we get to leave the hospital or the morgue setting sometimes and optionally attend scenes and assist with some of the scene investigations. So there's a little bit of different sense there. But I'm happy to answer questions in the individual sessions. Thank you.
Thank you. And next we'll have Dr. Gross from Bone and Soft Tissue Pathology.
Okay, so why do a Bone and Soft Tissue Fellowship? I'm John Gross. Here's my Twitter handle, and there's my email address if anyone wants to be in touch with me later. A little bit about me, as I kind of mentioned, I did my residency in Omaha, Nebraska, which is a small, it was a great program, but it was a smaller program. And now I'll kind of talk about that more in the breakout sessions. When it comes to fellowships, those of you, especially that are coming from a smaller program, I think you really want something a little bit different. And so I was fortunate enough to do a bone and soft tissue formal fellowship at the University of Washington in Seattle. And then I followed that, kind of went, most people do it the other way, but then I did a surgical pathology fellowship after the subspecialty fellowship at Mayo Clinic. I'm currently at Johns Hopkins, as mentioned, where I'm an associate professor. I started that spot. I moved here during COVID, which is kind of an awkward time for everyone. But now I'm the division director of bone and soft tissue pathology at Hopkins. And I'm the fellowship director, which our program will begin in 2026. Big picture for you guys at home, the way I kind of look at bone and soft tissue, and the way I look at pathology in general is that you have all these pieces of data, right? You know, what's the clinical history? What's the radiology? What's the gross histology, IHC, molecular? Rarely is any one of those categories like 100% sensitive or specific. 99% sometimes, whatever, nearly 100, but like I'm saying 100%, like you got to be 100% with these diagnoses. And so the goal of a pathologist or of a doctor is to have multiple different pieces of data kind of pointing towards one direction in an orthogonal manner. And, you know, certainly in bone and soft tissue versus other types of pathology specialties, IHC and molecular are very important constituents. Most trainees, pathologists in general, are experts in clinical histology, IHC, and molecular. They'll spit out SOX 10, 100, it has MDMT amplification, all sorts of stuff. But again, a lot of times that stuff is not specific. Again, you have to have many different pieces of data. And I think from a overall perspective, the radiology and the gross is very important in bone and soft tissue pathology. And that's something that I believe that's very valuable and somewhat undervalued. To be a bone and soft tissue pathologist, you have to really have at least a good grasp of radiology, and it's very fun. So it's a unique subspecialty within surgical pathology, and it combines the clinical radiology, gross histology, IHC, and molecular. And you're like a lawyer, you're integrating this information and you're building a case and you're prosecuting that tumor that way. And you're really working from head to toe. All specialties come to me for help. Neuropath, gyne, breast, GI, everybody comes to me for help. And connective tissue tumors are typically rare, but they're very common sources of diagnostic difficulty and expert consultation. Most academic centers want a fellowship trained bone and soft tissue pathologist in like 2025. And even if you don't want to subspecialize in bone and soft tissue pathology, maybe you have different plans, whatever. A bone and soft tissue fellowship training, right? That training is an incredible education and so valuable, which is applicable to honestly all specialties. It's a very exciting time to be a bone and soft tissue pathologist. You know, there's tumor discovery, sometimes with molecular diagnostics, and there's these international collaborations which are very common these days, and that's just a very exciting time to be a bone and soft tissue pathologist. So thank you very much.
Thank you so much for that wonderful information about bone and soft tissue. Dr. Jones, you're up next for neuropathology.
Today, I'm going to tell you a little bit about neuropathology. For those of you who aren't aware, neuropathology is under the anatomic pathology and then diagnostic surgical pathology area. And so we perform gross and microscopic examination of tissues from brain, spinal cord, also skeletal muscle and peripheral nerve, as well as eye, and then the surrounding tissues. And yes, we do go to our bone and soft tissue and hematopathologist colleagues and other colleagues because the surrounding tissues involve a lot of other specialty areas, and also many tumors metastasize to our organs. And so we have to have really close working relationships with other, both AP and CP specialties. So neuropathology, while it seems like it should be pretty straightforward, we actually have multiple fairly distinct divisions within neuropathology. And so first is neurosurgical pathology. Basically, anything a neurosurgeon removes from the patient would fall under the category of neurosurgical pathology. And so in that, we have really close working relationships with obviously the neurosurgeons, but also the neuroradiologists. Our gross exam is radiology, basically, in neuropathology. So neuroradiology is really important. And then, of course, the neuro-oncologists and neurologists who are then going to be taking the patient and deciding how to treat them after our diagnosis. Autopsy neuropathology is also an important part of neuropathology. So we have brain cutting sessions. These are typically separate from the rest of the autopsy. Brains get fixed in formalin for a week to 2 weeks, and then a formal brain cutting session is performed at most institutions. Brains can also be cut at the time of forensic and other autopsies fresh, and those aren't necessarily done by a neuropathologist, but as a neuropathologist, you get the more complicated cases. This includes neurodegenerative disease workups, as well as forensic neuropathology, which is a really important area. And we have close working relationships then on the neurodegenerative side with the neurologists that see these patients. And then all of this can be performed in hospitals, but it also obviously can be performed in a medical examiner or coroner setting. And then we have neuromuscular pathology, another area that falls under our heading. This involves skeletal muscle and peripheral nerve. And so you have close working relationships with your neuromuscular neurologists and then rheumatologists, those folks that will be seeing these patients regularly. This is performed by neuropathologists, but in some institutions it's actually performed by neurologists. And so it's important to recognize that can happen and where you're going to get your training, as well as where you are interested in practicing in the future. And similarly, ophthalmic pathology also falls under neuropath. This involves obviously the pathology of eye and the surrounding tissues. And so you have a close working relationship with ophthalmologists in neuropathology that performs eye pathology. This similarly can be performed by neuropathologists, but in some institutions it's actually performed by ophthalmologists. And so it depends where you're at. We need a lot of ancillary studies in neuropathology. We correlate closely with radiologic studies for brain tumors. We use immunohistochemistry, and molecular testing is extremely integral to what we do every day on the neurosurgical service. We use a lot of molecular testing, and neuropathology has actually pioneered a newer molecular test that involves methylation profiling for tumor classification. This has become something we're doing every single day in our practice. Neurodegenerative diseases, again, you need to correlate very closely with clinical information, and immunohistochemistry is key. For neuromuscular pathology, this is a little bit different. It's going to be more akin to what you'll hear about renal pathology, where we do specialized processing, we do specialized stains, sometimes immunofluorescent stains even, and then electron microscopy is really helpful. And eye pathology really requires, again, correlation with clinical information and immunohistochemistry. There are a lot of combinations that work with neuropathology really well, and so you'll see people who are interested in doing NP+, and so those would be something like pediatric pathology and neuropathology. A lot of pediatric hospitals really like having someone trained in neuropathology to do that work. Forensic pathology and neuropathology, extremely common. I have many friends who have gone into that area and been very successful in that. Molecular pathology and neuropathology, because of that close relationship, it's very helpful. So you can work in an academic medical center, you can work in a pediatric hospital, you can work in private practice and do neuropath and usually something else, some other surgical pathology specialty. You can work in a medical examiner's or coroner's office as a neuropathologist. And then there are neuropathology trained folks who work in for-profit companies, for pharmaceutical companies, for molecular testing companies like Foundation Medicine, for specialty pathology companies that only perform renal biopsies. Those are all options when you're trained in neuropathology. It would be obviously for muscle biopsies, but there's companies that do only muscle biopsies and renal biopsies. So as a neuropathologist, you can wear lots of different hats and different combinations of those hats. You can do diagnostic work that we talked about, but research is very common for neuropathologists to be involved in. You can have the physician scientist track where you're really 80% research and 20% clinical work. You can be a collaborating researcher where you do kind of the opposite, or you can just write some case series and case reports, and that's a very valid way to be a neuropathologist as well. When you combine those things, obviously, with teaching, we teach at all different levels, neuropathologists do, throughout medical education. And then also professional work is very common. So there are a lot of committee options, whether those are in your institution, national organizations like CAP has a really wonderful neuropathology committee. The American Association of Neuropathologists is our organization I'll tell you about in a minute. And then lab directorships are very common for neuropathologists to be involved in. Med ed leadership, neuropathology fellowship director roles. We have a number of chairs of departments that are neuropathologists, so that's also something that we can do. And there are various working groups. So the way to become a neuropathologist, you can do AP-CP for 4 years or AP only for 3 years and then do neuropathology, which is a 2-year fellowship. It is unique in that. But there is also a combined AP-NP residency and fellowship that the American Board of Pathology still allows, and that's a combined 4 years. So it shortens everything by about 1 to 2 years. And not every program offers that, but many do. I really suggest that you go, if you're interested in neuropathology, to our main organization here in the United States, the American Association of Neuropathologists. You can see the website at the top. You can find out a lot about neuropathology. we have a really great page where all of the current neuropathology fellowship openings are listed. So you can just go there and see what kinds of openings there are for each of the individual years. There's also a jobs board. So this is an example of some of the jobs that are available currently, and this gets updated regularly. So if you want to see what options there are for jobs in neuropathology, this is a great way to find out. And we do a lot of teaching, and a lot of this teaching is free and open to anyone. So this is our YouTube page. You can find many wonderful teaching round sessions done by expert neuropathologists where you can learn about all different areas of neuropathology just by going to this YouTube page and watching our lectures. So I'm happy to answer more questions when we do our breakout sessions. Thanks for the time.
Thank you so much. And next we'll have Dr. Chang with renal pathology.
So I trained in Seattle at the University of Washington doing my APCP training and then my renal path fellowship there. And then I joined the University of Chicago 21 years ago. And I'm really glad I stumbled upon renal path. I probably would have been a GI pathologist, but Charlie Alpers was, and he's still there in Seattle, super dynamic guy. That's sort of how I ended up where I am now. On a day-to-day basis, I probably evaluate, 4 to 10 kidney biopsies, and mostly native biopsies, but on occasion, quite a few transplant biopsies. And certainly those numbers are going up because most academic medical centers are trying to do more kidney transplants. We've also been pushing to make sure that our GU pathologists evaluate the non-neoplastic kidney in tumor nephrectomy specimens. And like I mentioned, this requires a 1-year fellowship in renal pathology. There's a few programs that have combined GU renal pathology fellowships, and we're pretty flexible. We would probably be willing to do that for any residents that are interested in doing both of those within a year. I think that's fairly reasonable. To recap, we look at a lot of colors in renal pathology. These are 4 of our very standard special stains that we're using with the H&E-PAS Jones and trichrome. We also have immunofluorescence. And so this is a standard panel. We actually recently got rid of fibrinogen and albumin, but a lot of labs still use those. So potentially you're looking at anywhere from 7 to 9 antibodies for all of your native kidney biopsy evaluations. And electron microscopy, right, is a pretty important part for at least, I would say, up to half of our biopsies. And so we're using that to try to figure out exactly what we're dealing with when we're looking at the kidney biopsy. And, that's really a fun part of what we do. We're literally piecing together all these different pieces of the puzzle. And I think we have a few more pieces that we get to piece together compared with some of the other surgical pathology subspecialties. No grossing. If you don't like grossing, come be a renal pathologist. I really enjoy the close interaction that we have with nephrologists and rheumatologists and our transplant surgeons, but mostly the nephrologists. I would say on every single kidney biopsy, I'm speaking with the nephrologist because it really requires the clinical context, which we don't always have because a lot of our biopsies are coming from other outside community hospitals and we're not connected to them with the electronic medical record. There's been an amazing explosion of therapeutics in kidney diseases, especially with IgA nephropathy, C3 glomerulopathy, ANCA-GN, thrombotic microangiopathy. And you can't give these patients brand new expensive drugs without a kidney biopsy. So we're really seeing our biopsy numbers jump up tremendously. And also this really tremendous interaction with pharma, actually, because they started to realize how important the pathologists were in this whole deal, right? Because we are the ones that make the diagnosis. Renal pathology remains really intellectually challenging. I've been doing this for 21 years, and I feel like I'm still learning. I'm still getting better at what I do. And like I mentioned, onconephrology is exploding. So all these new cancer therapies that are being given, checkpoint inhibitors, VEGF inhibitors, tyrosine kinase inhibitors, they all have some sort of impact on the kidney. And it's pretty fascinating for us to try to figure that out when you have these cancer patients who are developing kidney injury, in the setting of all these therapies that they're getting. Fascinating thing now with xenotransplants, maybe it won't be too long before we start looking at pig histology. And there's a huge, massive shortage of renal pathologists. So there's a ton of job openings. And also as a result of this, I think there are more speaking and leadership opportunities within the Renal Pathology Society and just in general. I think in the last session, it was mentioned that there are a lot of neuropathologists who are chairs. There's a lot of program directors I'm aware of who are renal pathologists. I think we have a bit more time on our hands to be involved with administrative duties and things like that, if you're interested in that, or teaching. My colleague, Cami Henriksen, directs one of the first-year med school courses here at the University of Chicago. I guess, the con is that you really have to be proactive about getting exposure to renal pathology potentially. There's plenty of programs that probably don't have fellowship-trained renal pathologists. And I guess one thing is that there are private groups that have renal pathologists, but it's mostly academic centers that have electron microscopes. So you're potentially geographically limited, but if you combine this with GU, it definitely adds flexibility. Here's a travel grant that ASN, the American Society of Nephrology, actually is offering to med students and residents. It's not clear from the instructions, but they do give out these travel grants to trainees who are interested in renal pathology. So with that, that's my last slide. Thanks so much, everyone.
Thank you so much for all that information. Next, we have Dr. Kreiger for Peds Path and a little bit of digital informatics.
Great, thank you. Just as a brief background for myself, I did my general anatomic pathology residency at Penn, and then I did a pediatric pathology fellowship at the Children's Hospital of Philadelphia. And about pediatric pathology in general, so pediatric pathology, although it's a subspecialty of pathology, it's a very broad and general field. In pediatric pathology, see all pathology related to the fetus, neonate, infant, and child, all the way up into adulthood. So you really see a little bit of everything. And the thing I'll say, people ask me, why is pediatric pathology a subspecialty? I think the truth is that children really aren't little adults. That old saying is absolutely true. The things we see in pediatric pathology are quite different than what one sees in adult pathology. For example, we see a lot of developmental issues. So we get specimens from children that are often congenital, and we have to kind of put the pieces together to figure out what the pathology is. Also, in the area of cancer, I will say that carcinomas in children are exceedingly rare. What we see more of is, brain tumors, leukemia, lymphomas, and then in the solid tumor category, a lot of small round blue cell tumors like Ewing sarcoma, rhabdomyosarcoma, things like that. So the things that we see in pediatric pathology are quite different than what one sees in adulthood. As far as what I love about pediatric pathology, I love the fact that it is a subspecialty that is still very broad. So I have a whole shelf of books that are split up by organ system. So I have books on bone pathology, renal pathology, liver pathology, GI pathology, you name it. I have a section of books on that entity. And it's quite frequent that I'm pulling them off the shelf and I'm trying to put things together with the clinical history, with the imaging. It's very similar to what was described for bone and soft tissue and for renal pathologies, that you're really putting the pieces of a puzzle together. And I really like that aspect of my practice. And like I said, if you like development, I think pediatric pathology is an interesting area, but it's a very broad area. So it also incorporates a lot of, we do autopsy, we do surgical pathology, we do some cytopathology, we do a little bit of everything. As far as my typical day, this will vary a little bit by location to location, but at CHOP, first thing in the morning, we have our morning huddle. We're a relatively small division, so we have a lot of interaction with our staff. So our histology lab, our gross room, and our autopsy suite are all in the same location as all of our pathologist offices. So we have a very tight-knit community in our division where we interact a lot with our staff. So we start our morning with AM huddle. We have our consensus conference with all of our pathologists, our trainees, and we do have 2 fellows a year and numerous residents that rotate with us generally month by month from sort of the whole region of Philadelphia, Pennsylvania, New Jersey. We interact with our clinicians quite a bit. So we're situated right in the main hospital on the 5th floor. So our clinicians come by quite frequently to look at cases with us. And that's something that I really enjoy. And our clinicians are really wonderful at CHOP. I will say, the one thing that might be different about a children's hospital is just the sort of culture in general is very friendly. People are very collegial, generally happy and easy to work with. And just the environment, when you walk into a children's hospital, you get a different vibe because they try to make it child friendly. Additional training needed. So it's just a 1-year fellowship. So I did AP only. You can do AP only, or you can do AP and CP. And then you just have to do 1 year of fellowship beyond that. A trend currently is people are doing multiple fellowships. You really don't have to do that for pediatric pathology, but you can. Some strong combos I've seen. One of my colleagues did both pediatric pathology and molecular pathology, and she attends both in our genomics lab and in anatomic pathology. Certainly, neuropath was mentioned previously. That's a really strong combination. Renal pathology would be a strong combination. We have a dermatopathologist who also did pediatric pathology. I think that's a really unique and strong combination. We see a lot of GI pathology in pediatric practice. As you can imagine, a lot of kids present with belly pain, and so a lot of them end up getting endoscopies. And so we get a lot of GI biopsies. So if you like GI and liver, PedsPath is a great place to see a lot of that. But almost any combination will work. We have a forensic pathologist who also does PedsPath. We have actually a blood banker who splits her time between the blood bank and pediatric pathology. So like I said, almost any combination will work with pediatric pathology. As far as how students and residents can get involved, I will say that we are seeing a huge shortage of pediatric pathologists. So I can see with almost 100% certainty that if you were to reach out to a pediatric pathologist at your local site, they would be very excited to work with you, whether you rotate with them, observe with them, do a project with them. I am sure that they would be very eager to get you connected with pediatric pathology as a discipline. We also have a society called the Society for Pediatric Pathology that offers a case report section for trainees. They also offer short study stipends to go learn pediatric pathology at another location. So definitely check out spponline.org. There are lots of opportunities through our national organization as well. And pediatric pathology is a pretty tight-knit community. So I know pediatric pathologists from all over the country, which is really fun to be able to know your colleagues across the country and even outside the US. So I would say if you're someone who really likes an academic environment, but you still want to be a generalist pathologist, PedsPath is a great option for you. If you like developmental biology, PedsPath can be great. If you want to help children, PedsPath could be great. If you want to combine PedsPath with something else, like I said, almost any combo would work. I've gotten very involved in digital pathology. I will say that we, as a children's hospital, tend to be pretty well resourced. And so we have the ability to do digital pathology. So we brought on whole slide scanners a few years ago and we digitize all of our slides. We're now moving in the direction of creating AI algorithms for pediatric disease. So there's a lot of opportunity in digital pathology and clinical informatics. I would say, PedsPath is a great discipline. There's lots of job openings. We are seeing a shortage. You can practice in a children's hospital setting. You can practice in a larger academic group. There's just lots and lots of opportunities there. And I will stop there, and I'm excited to chat with everyone in the breakout sessions. Thanks.
Thank you so much. And next we have Dr. Lyapichev talking about hematopathology.
Hi. So first of all, I would like to thank you guys to invite me to represent my favorite subspecialty, which is hematopathology. My name is Dr. Lyapichev. It's kind of difficult last name. So my prior residents, medical students call me Dr. L, and it's fine with me as long as we can build the communication better. I finished my APCP training back at University of Miami, Florida. After I went for 3 years fellowship at MD Anderson Cancer Center in Texas, Houston. I finished hematopathology fellowship, advanced hematopathology fellowship, and molecular pathology fellowship. After that, I was invited to be a hematopathology and flow cytometry director at University of Texas Medical Branch at Galveston. And recently I moved back home, which I'm considering Florida and Miami area, to Cleveland Clinic, Florida, where I am director of flow cytometry and I'm hematopathologist. So hematopathology, it's a kind of unique subspecialty, I think. I believe for every speaker, it's a unique and nice subspecialty, the best and so on. And for me as well, in order to be a good hematopathologist, you need to be very knowledgeable at clinical pathology and anatomical pathology. Of course, sometimes there is exceptions where people finish in only AP or CP part. I personally believe both parts are very important. Hematopathology require fellowship, as you might heard on my experience. It can be 1 year, 2 years, and it's require board certification, so additional board. Hematopathology is very involved. Diagnostics and hematopathology involve molecular pathology. That's why you might see a lot of hematopathologists who are double board certified with molecular pathology. So the understanding and certification of molecular, it's very helpful, I would say. So what hematopathologist is doing It's diagnosing benign hematology disorders and neoplastic malignant hematology, which is involved in bone marrow or blood or lymph nodes or everywhere aberrant lymphocytes can involved, from brain to bones and everywhere. So we are basically the ones who are making diagnosis of lymphomas and leukemias. Diagnostics of hematopathology involved a lot of puzzles, as some of my colleagues already mentioned about their subspecialty, but I kind of think that, and maybe I'm biased, that hematopathology has more puzzles to put together. So we are evaluating histology, cytomorphology, immunohistochemistry. I think most of the stains, at least the highest number of immunohistochemical stains, belong to hematopathology. We evaluate flow cytometry results, cytogenetics, and molecular NGS. Of course, the imaging and clinical history is extremely important as well. And putting all these puzzles in one picture is very important. So what I like about hematopathology and why I chose it, that's partially what I already mentioned. It's an amount of tools I can have and I can use to make a precise diagnosis. If one tool didn't work or didn't show exact results that I'm expecting or cannot be performed, I can try to use the different tools and still try to get into right and precise diagnosis. Another thing, it's no formalin and no dead bodies. So it's like, who has an issues with smell or doesn't like to gross? That's your subspecialty. So you are like using your brain and cup of coffee if somebody's drinking coffee. As our colleagues mentioned, there is somebody showing cases to somebody, depends on subspecialty. In my experience, I'm the one everyone is showing cases. I'm rarely going to our subspecialty to show my case. I mean, it's possible, but it's usually now a way around. How my day looks like, the regular day in the morning, I usually started with a very good cup of coffee. And I evaluate the results on flow cytometry, on my cases, on flow cytometry, histology, and clinical history. And based on the combination of these results, I'm ordering immunohistochemistry on tissue or additional molecular studies, which needs to be done on certain biopsies. Then I am evaluating aspirate smears on bone marrows and peripheral blood. I'm doing appropriate counts. By that time, I'm receiving immunohistochemistry back, and I'm putting this puzzle in, and I'm ordering another set of immunohistochemistry, or I am modifying my report or releasing my report. That's about it. That's how the days go. In academia center, I usually teach residents. We had like sessions, lectures, interesting case introduction, or we discuss them, discussion. That's about it. And I'm looking forward to talk to potentially future hematopathologists or people who is considering hematopathology as their future. I hope to convince somebody to choose this wonderful specialty.
Thank you so much, Dr. L. It's funny you said no autopsy, because I'm currently working up a case right now waiting for IHC on a woman who was acting irregularly and then died, and she has some sort of lymphoproliferative tumor throughout like her whole body. So, so last but not least, with the lovely pictomicrograph of what looks like a vascular tumor to me from here, Dr. Lin for cardiothoracic pathology.
And autopsy. So we do need to talk a little bit about dead body, unfortunately, for some of you. Yes, I am a cardiothoracic pathology, and also I'm the autopsy service director here at WashU Barrington Jewish Hospital. This is actually what I do. So it's a broad spectrum, right? The left-hand side is actually endomyocardial biopsy. I also still do gross examination whenever I can. I love to get that formalin smell, put my hands on the organ. I see Dr. Elliott smiling. And autopsy, then we're dealing with the whole body. Well, this is actually, I'm a pro anatomic pathology. This is not the correct skill. It's more like this, like, the small biopsy I deal with, like from small biopsy to the whole body, and that's part of the fun. So why cardiothoracic pathology and autopsy? As I say, it's actually the diversity and the complexity. I deal with a lot of different organs. When I talk about the thorax, it's lung, heart, thymus, vascular, sometimes even, esophagus and some peripheral neural disease. For the rest, that we sometimes, it's kind of like historically we call cases kind of like surgical or medical, which doesn't really, make sense because pretty much everything is surgical and medical, right? You need to do a biopsy to get a medical kidney or medical lung. But cardiothoracic pathology, it's subspecialized, but you still feel you're practicing a general pathology. Why? Because you do cancer cases, which is quote unquote surgical. You do medical cases, which is like rejection, transplant, allograft, medical lung, interstitial lung disease. Every day I need to use a whole set of skill sets, all the way from anatomy when I do the gross examination, the histology under the microscope, molecular pathology for genetic disorder for the cardiomyopathy or the lung cancer, treatment or treatment resistant mutation. So it's like a full spectrum. Like every day I feel I'm like practicing in the subspecialty setting, but I'm still practicing the very general, very broad. There's not a dull moment. There's not one day I don't learn something new or feel excited about my field. And then this is actually a field I will argue that very easy to incorporate the traditional tripod mission, the clinical practice education and research. Although you can argue that can be said for a lot of different subspecialties that has been introduced today. I don't want to spend just like a few minutes of hospital autopsy. We heard several great things about forensic autopsy. Hospital autopsy is kind of like a different setting, and people will argue that it might be a dying art or even already quote unquote dead. The ABP, the American Board of Pathology, recently decreased the amount of autopsy for residents need to sit on the board from 50 to 30. However, it's really sad to see that trend, because hospital autopsy is still very essential and necessary to provide the patient quality and safety in the hospital system and to advance our understanding of pathophysiology. The most recent sample, unfortunately, will be the SARS-CoV-2, the COVID-19 pandemic, that the hospital autopsy and forensic autopsy is actually really fundamental to understand this new emerging disease. Cardiothoracic pathology and hospital autopsy, not forensic autopsy, it doesn't require a subspecialty board. They do have some fellowship opportunity for either cardiovascular pathology, pulmonary pathology, or some of the programs have cardiothoracic pathology. As of now, I do not believe there is a hospital autopsy fellowship, but I do really hope that one day there will be, because it is a really great need area that we are lacking pathologists to devote their career in this specific field. My day at work is actually just kind of like any academic pathology. I mean, you sign out cases, you work with the resident and fellow. I still do research all the way from basic mouse genetic research to imaging clinical trial. I really enjoy being a cardiothoracic pathology. Part of it is like working with multidisciplinary team. Like the picture here is actually our heart transplant team that we have a multidisciplinary conference every single week to discuss the patients that is undergoing transplant or having allograft surveillance. Last but not least, I've been involved in multiple society. CAP for sure is one of them. I didn't put the CAP logo here. Shame on me, I should have. But there's a lot of great pathology societies like USCAP, and specifically for heart and lung, like Pathology Society, Society for Cardiovascular Pathology. ISHT is a multidisciplinary society that's for heart and lung transplantation. All of these societies I've been involved in are very dedicated to increase the education support to medical student or resident to go into our field. So, I'm looking forward to have very fruitful discussion with you all in the breakout session. Thank you.
Great, thank you all so much. This next portion of the event will involve about 9 7-minute breakout sessions with each panelist. Each session will have about 3 attendees paired with each panelist. So attendees, please unmute. Feel free to turn on your video and engage with the panelist. When the session is up, attendees will switch to the next breakout session. So everybody here today will have the opportunity to engage with each panelist. King, Lizzie, and several of our other PathSig and CAP members will be present with each panelist just in case there are any technical issues. I'll stay out here in the main session, so if you lose your connection, feel free to rejoin and I'll assist you with re-entering your breakout room. And with that, I'm going to go ahead and open up the room, so feel free to head over and just let us know if you need anything. With that, we'd like to thank you all for sticking with us today and for your thoughtful participation throughout the session. We know we ran a little bit over time, but we do really appreciate your patience and engagement. As a reminder, the main session was recorded and will be available on our website within the next few days. If you're not already following us, you can find us on Instagram, X, Facebook, TikTok, LinkedIn at path_SIG, as well as at cat_pathologists. We'd love to stay connected and we welcome your feedback. That wraps up today's session. Again, thank you all so much to our incredible panelists and to all of you for joining us. Have a great rest of your day.
Thank you. Bye.
Thank you.
Bye. Thank you.
Have a good day then.